Hi, we are deprescribing.org. Our research team develops evidence-based guidelines for deprescribing. This is one of 2 videos where we will walk you through a case example showing how to use the Statin Deprescribing Guideline. This guideline applies to people 65 years or older that are taking a statin for primary or secondary cardiovascular prevention and are not having any side effects. If you haven't seen our first video, which explains the guideline and algorithm in more detail, we encourage you to check it out using the link in the description below. For our next case, let's meet Jane, a 74-year-old female with terminal lung cancer. You have been helping care for Jane since she moved into long-term care 2 months ago. The nursing staff at the long-term care home are asking for a review of her medications, as she is often refusing them. She has multiple medical conditions, including a heart attack 10 years ago and advanced dementia. Jane takes several medications every day, one of which is rosuvastatin 20 milligrams daily that was started after her heart attack. You see in her chart that she mainly stays in bed and requires staff to assist with all of her care. She isn't eating well and has been losing weight. Her husband of 53 years is her substitute decision maker and is very involved in her day-to-day care. He is heartbroken over her declining health and is adamant that he wants her to be comfortable and have dignity with whatever time she has left. Looking at our statin deprescribing algorithm, we can see that Jane has several factors that would prompt a conversation about stopping a statin. Importantly, given Jane's health, she's likely at end of life. The algorithm would lead us to consider discontinuing the statin. However, each person may feel differently about this suggestion, and it's important to have a conversation with patients and carers about their goals and preferences. You meet with Jane's husband, John, to talk about Jane's current health and all the medications she's on. You ask if John has any questions or concerns. He confirms that Jane seems very bothered by taking pills and often refuses them. When you bring up possibly stopping the rosuvastatin, you explain that when someone is nearing end of life, there is less of a concern for harm with stopping statins. So far, the evidence doesn't seem to show that continuing a statin would make any difference on Jane's risk of dying in the next few months or having another cardiovascular event in the next year. You ask about his preferences and goals for his wife. He again brings up that making her comfortable and happy are the most important things, and taking less pills would be nice. So together, you decide to stop the statin. Evidence does not suggest the need to taper the rosuvastatin when stopping. For people at end of life, there is generally no role for monitoring after a statin is stopped. You take the time to explain to Jane's husband that he can always reach out to you if he changes his mind. You then take the opportunity to summarize the conversation in Jane's patient record and discuss the outcome with her nurse. You then write a new prescription to communicate the change to the pharmacy. We hope you found this example helpful in understanding how to use the statin deprescribing algorithm for people at end of life. Remember, the goal of deprescribing is to reduce medication burden and harm while maintaining or improving quality of life. It should always be done with planning and supervision by a healthcare professional to make sure it's appropriate and safe. Finally, we would like to say a big thank you to our guideline panel and staff and to our funders and partners.